Well, good afternoon, and thank you for joining us. You've landed at the CAF COVID Weekly Roundup, and my name is Jason Belden. I am the Director of Emergency Preparedness with CAF, and I'm not sure if Patty's going to be able to join us. I know she's working on a draft AFL comments to go back to CDPH, so she may not be able to join us, but I'll update us on where we see the AFLs going in the next couple weeks. We'll talk about vaccine CDC changes. I know that's been a big topic of conversation, as well as equipment and equipment specific to infection prevention and infection control. Today is February 12th, 2021. Happy Friday to all you guys. And as always, you can always check out caf.org for resources on coronavirus. We also have a separate section of that webpage dedicated to vaccine resources as we identify them. All right, let's hop into our normal preamble. Today's presentation, the speaker's opinions expressed are their own, and that's just going to be me today, I think. Sometimes they may not reflect CAF's official position, and where that's the case, I'll try to indicate it's my own personal opinion. Grant-funded program. This is brought to you by a grant-funded program through CDPH and the Los Angeles County Department of Health Services. We have no financial conflicts. And the intent of the webinars has been to try to give you a situational awareness or a situational report of the week's activities in COVID response, highlight forecasting and best practices where we can see those. Today's presentation is going to be very light, so hopefully you guys will be able to get out of here soon, or if you have lots of questions, we'll handle those as well. So if you see on the right hand side, there should be a question box. Go ahead and drop your questions in there, and I'll get to them at the end of the presentation. So, and like I was saying, today we don't have a whole lot of changes. So that's good news for you guys. That's great news. So we don't have a lot of topics to cover, but I am going to talk just briefly about what AFLs are in draft now and what you can expect to see coming very soon. There are a number of AFLs in draft that will make substantial modifications to operations, and obviously, no, some of those changes are going to come in the form of mitigation plan changes based on what we know of the vaccine, but that may be a little further down the road. As of now, we do know that there's we've had a chance to review a vaccine distribution AFL that's going to come out to folks about what to do about second dose and things like that. I expect that's probably going to land maybe today or sometime next week. It's not going to be very soon, but it should give us more concrete guidance on where we go for second dose, especially those of you with concerns about getting the second dose after the third clinic is gone. There are other AFLs in draft. One of them is going to be a really substantial AFL on staffing audits. We went through it, it was like a 15-page AFL, and we went through it line by line. We have very significant concerns with a number of elements within the draft AFL that we don't think, well, we just think there's a lot of room for improvement. And so CDPH has reached out to us, and we're going to have a work group together to discuss both that AFL and then the step down procedures. So CAF sent a set of recommendations, and I'm happy to share them with you guys offline. We're not going to make them public because they're drafts, and we plan on sitting down with CDPH with their infection prevention team to go through each of the components that we have recommended. We've recommended changes to obviously to visitation, to group activities, to communal activities, outside visits. We put together a large set of recommendations, and we'll go through those line by line. I don't think what we have sent them is very controversial or will cause much problems. I think there's a lot of consistency across the country in terms of talking about the elements that need to go into these step down plans. It's more like, what do we do with non-vaccinated people versus vaccinated people? And I think there's still some there's still it's still up in the air. We don't know how CDPH or CDC is really going to, whether they're going to be big changes or whether it's going to be small incremental steps as we and we may have multiple step downs to this, you know, kind of peeking our head out of the ground to see if it's clear to come out, and provided there's no you know, the vaccine is doing what we hope it does, then maybe we can remove some of those barriers. But we expect that to be probably within the next week or two. There's a lot of work that goes into it, and I don't really feel like the state feels like they have enough data to really do anything substantial in the first go in terms of removing some of these requirements. And I'm just going to be frank, it might be another you know, month or so before we see real significant operational changes. All right, so I want to hop to vaccine second dose concerns. I know, gosh, this is a big topic of a conversation, and I want to just reiterate that we have both CAF and AHCA, our national association, have been in conversations with CVS and Walgreens, and from the top, when we talk to them, they assure us that first dose clinics will be given on the third clinic date. We have heard, obviously, that is not always what is happening out in the field. And in those instances, what the only successful method that we have identified was to contact the local health departments and to get them, give them situational awareness about how many doses you need, when you need that second dose, what was the, we're going to assume it's Pfizer, but you know, if there's a difference in medication, you would want to notify them of that. If it's Moderna, it could, you know, there could be other issues with supply side that they would have to figure out. If the local health departments have are unresponsive to your requests when you know this is coming up, the other option is to talk to your large acute hospital partners, and those that have operations across multiple counties, and they're called multiple county entities. And those folks, like the Kaisers, Dignity, Sutters, you know, the list goes on. That's not a comprehensive list, but those folks get a direct shipment, and they're supposed to follow the same priority schedule that the local health departments are following, meaning that anybody that gets these doses, no matter who they are, is supposed to be following a priority list of who to give the vaccinations to. And our folks, even if after the CVS and Walgreens is done, our folks are still in tier 1A. They're the most important people to get vaccines. And so in your communication with these health departments, you want to maybe not, you know, say you have to, but at least point out the fact that these folks are still within tier 1A and we're missing folks. I want to give the health departments credit. At least the ones that I have spoken to have been incredibly responsive and reached out to the providers right away to let them know that they would be working on the issue. Now, whether that, you know, turns into shots in arms, I don't know, but at least they have acknowledged the problem and are working it from their side. And at this point, there's not much else CAF can really do on your behalf. It helps if you tell me, and I can send an email to the health director or somebody at CDPH to get more eyes on it. But really, that's kind of our only real responsive outcome at this point. We've not had very good luck at sourcing these from those multi-county entities, but because you have relationships with individuals, acute hospital providers, you may be more successful in negotiating that. I certainly know the hospitals early on were, at least some of them were raising their hand to be able to support our mission to vaccinate folks. And so I do know that some folks in the acute community feel like it's important So if you can leverage that kind of relationship you have, I think those folks might also have ability to get that second dose for you guys. And this would go for first dose too, for new residents, for new staff. If you've already completed CVS and Walgreens, those folks still don't have a mechanism to be able to get them vaccinated, and the local health departments will need to know about that. But that's a kind of a separate issue, and that really we've kind of got to divide that out. The second dose obviously has a finite time when they can give those. The other things, they'll probably want to schedule it around you getting enough people so that they don't have to waste a vial. So if you had one new resident, it may not make sense for them to send out a vial for you just to vaccinate one person. So, and I did want to let you guys know that both CVS and Rite Aid in the state of California, their retail program is open. You can go on either one of those websites and schedule folks. So if you have staff that have not got vaccinations, they can go through these CVS and Rite Aid federal retail programs. When they go through the registration process, there's a drop-down menu that allows you to choose healthcare worker, and that will automatically put you in the primary one priority and allow you the ability to schedule an appointment. At the moment, they haven't got a lot of doses. I think about 100,000 nationally. So it's not a ton, but there is some access there. And I went onto the website this morning. I've not gone on CVS yet, but I went onto the Rite Aid website to see, you know, what it looks like and how easy or difficult it is to get registered. And you guys, your staff, anybody should be able to figure this out. It's a one-page form and takes about 30 seconds to fill out. So hopefully those, you know, between those three, that's really what we've got at the moment. We do expect more information to come out very soon, though. In terms of ongoing vaccinations, the supply is really driving the lack of clarity. Many of you have heard Blue Shield was hired to be kind of the point for distribution of vaccines throughout the state. But as of yet, that decision-making process and what's going into it is not transparent at the moment. And we're not able to see what, if any, plan or has been given to the ongoing vaccination mission within our facilities. We have worked, we have sent, you know, letter after letter to the state really recommending we utilize the existing long-term care pharmacy structure. And if not, then we need to get you guys signed up with CalVax and CARE so that you can be registered immunizers if the plan is to send you medication. At this point, they have not told us to do that. I still think it's going to be a possibility unless they decide to empower the long-term care pharmacies. In terms of alternatives, we kind of talk about, you know, what are some of the other alternatives for sourcing sourcing second or first dose. In terms of what's coming, we do know there are a number of other vaccines in the pipeline that should be coming fairly soon. In terms of EUA approval. The reason why I bring that up is because of the storage and the one-dose administration. It may be at some point we convert from using Pfizer or Moderna to a supply that can be housed on site in every building rather than just those with the ability to have cold chain storage. So I think that is a possibility, but we're a few months away, I think, from really seeing whether that's going to be applied in our setting. So if you're thinking that's coming soon, I think one, we've got to worry about supply side. You know, the vaccines that we're using now or that we used at the beginning of this had been in production for months before the EUA was approved, and I'm not certain that that same supply is going to be available the minute the other vaccines get their EUA approval. So it may be we may have less capacity or supply with those individual things, which we don't want to get into a spot like we are now where we're worrying about where the next vaccine is going to come from. So in terms of vaccine, that's what staff knows at this point. I wish I had more concrete information for you guys. I really do. I just at this point we're all confused, not just us in long-term care, but the public at large. So I wanted to go over these CDC changes that go into the clinical considerations of the 2 mRNA vaccines and talk about some of the updated quarantine recommendations they had for vaccinated persons. So I'm going to go through this, and it was multiple things within the CDC change, and it wasn't just the quarantine. And I know that's what brought caught everybody's attention. It certainly caught mine. But in terms of the CDC changes, they do have new recommendations for preventing, reporting, and managing vaccine administration errors. Obviously, folks need to be, aware of the process to report administration errors and vaccine adverse events. Within that guidance, it has links to both of those documents that tell you how to report vaccine administration errors, as well as the VAERS system. There's a clarification on contraindications and precautions for the vaccine. And this one has some detail to it, and I'm going to read it to try to give you some kind of idea, because I'm obviously not a clinician. I don't want to speak out of turn on this, but there was, I believe, they listed specific products within the medium of the vaccine that could cause potential issues. And I'm going to I think it was PEG, and I'm trying to find the issue, and I'm sorry guys, I bookmarked it, now I can't find this thing. Anyways, I'll grab the issue, but it certainly did say that there were certain things within the medium itself, not necessarily the medication, but that you may be allergic to, and one of those was PEG. So if you had an allergic reaction to that, and the other one was started with poly something. I'll find the information for you guys before we end. There's updated information on delayed and local injection site reactions after the first mRNA vaccine dose, and those have to do with anaphylaxis. Updated quarantine recommendations for vaccinated persons, and I know that's the one everybody wants to hear about. So let's go ahead and kind of dive into what the CDC said about that. CDC says these criteria. So, well, let's go back and let's just read what it says about the vaccination for in terms of quarantine for the normal public. So public health recommendations for vaccinated persons basically says in the efficacy of the vaccines against emerging SARS is not known. Vaccinated persons should continue to follow current guidance to protect themselves and others, including wearing a mask, staying 6 feet from others, avoiding crowds, avoiding poorly ventilated spaces, coughing or sneezing, washing hands often, and following the CDC travel guidance. However, vaccinated persons with an exposure to someone with suspected or confirmed COVID-19 are not required to quarantine if they meet all of the following criteria. All are fully vaccinated post 2 weeks following the receipt of the second dose, are within 3 months of the second dose, and have remained asymptomatic since the current COVID-19 exposure. So that's what it says, and that caught the attention. Everybody looked at that and said, "Holy cow, that sounds great! Now we can we can get back to being open." But of course, it went on to further clarify that these criteria could also be applied when considered work restrictions for fully vaccinated healthcare personnel with high-risk exposure, and that's underlined because that's the information on risk exposures that we had highlighted week before last. And but that's a link. If you click on it, it'll take you directly to the high-risk exposures. Vaccinated inpatients and residents in healthcare settings should continue to quarantine. So for residents, they're going to have the same. Even under this guidance, they would follow the same quarantine requirements. And the key phrase here is as a strategy to alleviate staffing shortages. And there's not really a hard and fast definition to the staffing shortages. And I've seen a couple questions from providers asking the state what defines a clinical staffing shortage. Maybe Patty has a better idea than me, but I don't know. When I look at a staffing shortage and we look at the other staffing AFL, it says that a staffing shortage is defined as anything that negatively impacts operations or patient care. And that's a really broad kind of term. I think it gives you the option to really identify whether this is a true staffing shortage or not. And it doesn't have to apply to just care staff. A great example would be, you had your dietary staff, and let's say you've got seven folks in there, and 4 have taken the vaccine and 3 have not. And the 3 have not, one of those 3 comes down with a case. Now, if you lose all of your dining staff, that causes operational issues. So for those folks that were already vaccinated, I think our recommendation would create a staffing shortage that would affect operations. And in those instances, I think that would meet this criteria. Now, that's my personal opinion. This is, like I said, a lot of that would be really surveyor discretion as to how you're defining the staffing shortage. But I do know that the information is out there. How you utilize it, just be careful that you want to justify that you are in a staffing shortage if you're having these folks work, after having an exposure. And it goes on to say this exception is due to the unknown vaccine effectiveness in this population that has higher risk of severe disease and death, along with challenges of social distancing in our setting. So I wanted to cover that. It is not a blanket. We get to jump right into this. It's really tied into staffing and whether that staffing is affecting operations or patient care. All right, we're gonna hop to the next slide. And let's talk for a second about infection control devices. I know, I get a ton of questions about, God, what should I buy? What is best practice? Things like that. And I don't know. And from what in terms of products, I can't give you a specific recommendation. I don't have any experience with these UVC products prior to COVID. And from what we know about how COVID is transmitted within our buildings, I think that this would be like one of the latter parts of the administrative barriers or environmental barriers that you could utilize to be able to do that. I think you want to look at all of the stuff to make sure that you're doing all the quote unquote core principles, the distancing and source control and washing our hands and all that good stuff. I think that is all primary, and that is the most important. And then when we look at stuff that we can't see or is new for us, I just think, somebody gave the scenario where you had multiple people working in an office that was small, that they couldn't manage a 6-foot distance between the two. And in that instance, I almost think that cleaning the air would be more appropriate, provided you're still cleaning the surfaces. And but like I said, that based on what we've seen in terms of transmission, it just seems like that may be a more effective intervention. But it's, we're grasping at straws here, and there's a lot of unknowns with these in terms of their effectiveness and things like that. And folks that sell them will sell you the moon, but I don't know, and I wish I could give you some guidance on it. And I'll do better about learning about these devices. But what I will say is that the FDA has created a couple of guidance documents. The first one has to do with specifically those UV lights for disinfection as it relates to the coronavirus. But the FDA also has recommendations on air purifiers and disinfectants to be used for the current thing, or for the current response. And I will say that as a best practice, I would look for, if you're looking at purchasing devices, to meet the need. I've got CARES Act funds. I want to do all I can. I want to create the safest environment I can. I would really, counsel you to look for other things that serve, or look for devices that serve multiple purposes. So if, this obviously makes sense probably to you guys, but in terms of the UVC lights, I've seen different products out there, and some of them are incredibly expensive and some are really inexpensive. And there's a drastic difference between what they will prepare or protect you from. And so as you look at that, I would try to, if I'm going to purchase one of these, I'm going to try to make sure I can use it for other stuff too. And we've mentioned C. auris or Candida auris. That's a big one that's in our buildings now. There are a number of other things that I would want to make sure that any infection prevention device that I purchase would have not just purpose now, but purpose for the future. All right. So in terms of what's coming down the schedule for these webinars and for existing webinars through CAF, I believe that HSAG and CDPH will continue their webinars and calls at least through March is my guess, maybe even later. The same with CAF. I'm going to hold these webinars through March 26th. And then about the middle of March, maybe a month from now, we'll revisit the duration and frequency. It may be we just cut these back to a half an hour, or cut them back to every other week. My hope is that once we see big changes to the mitigation plan, we can give you guys that information. And we can start cutting those back because those will be big changes that will affect our operations, and we'll have to cover those in depth. And then once we finish, kind of this schedule, we're going to have targeted education. I mentioned the demobilization on those step-down procedures. That will be pretty quickly. We'll provide education on that. I'm just finishing the editing of the respiratory protection Train the Trainer program, and that will be freely available on the CAF Disaster Prep website. Once I finish editing, I'm going to get it up on the website. And this protection or Train the Trainer program is not just a fit testing program, but it's a Train the Trainer program on not, doing qualitative fit tests. So you're going to learn how to do that, but learning about each different kind of respiratory protection and how that applies within long-term care. And then and once we do that, we'll have an after action reporting and improvement planning webinar. That will be separate from this particular webinar. And we'll figure out the method for that. And I'm going to try to make that free as well so that everybody gets a chance to participate in that. And then we'll do some recovery work groups or recovery webinars. These may be recorded, I'm not sure. It's going to cover a number of different things. One is, financial auditing. That's going to be a big one. But the other part is, behavioral health and taking care of ourselves and the process of taking care of each other. So we'll revisit all of that stuff in the coming months, I think, as we wind our way down to this. The good news, if you're looking for a spot of good news, I know the vaccine number, where you're going to get these vaccines is a crazy, crazy time right now. But incredibly good news that virtually no active cases in SNFs at the moment. I mean, the number is well, I should say very little new cases. Obviously, you guys have cases in your building, but if we go a day or two and we only have 10 or 12 new cases in the state, that's a great day, and that's a big drop from having 600 or 800 in a day. So you guys are doing fantastic. I'm going to hop to questions now. That was the last my update, and we'll see if we've got any questions here. All right. So first question, can you briefly go over the POC test reporting tool? Let me see if I can expand this question. I can't read the whole thing. I'm sorry. Yeah, let me see here. How do I? Oh, sorry. Forgive me, guys. Oh, okay. Can you briefly go over the POC reporting tool? Is it a requirement or optional? So if you use a point of care antigen testing device, whether it's in screening or your response testing, it's a requirement to report those test results. It's not optional. You have to report every one of the tests. Now, we did recommend to them, and I gave them a strong recommendation to CDPH that as we step this down, we want to utilize the point of care testing devices, but we don't want to have to report anymore. And so that's one of our big asks. Who knows if they're going to say yes to that? But right now, if you use a POC test device, you have to report it, unless you're a part of the pilot project, which has different reporting requirements. But that's a separate thing. If an employee was positive within the last month and has got vaccine, do they need to quarantine if they get exposed to confirmed positives outside of work? Well, we just kind of read the guidance from CDC, and I think the CDC says if you're in a staffing crisis, we don't have a great definition for that, but if you're in a staffing shortage, then you would have the ability to have that person work if they're post-vaccine 2 weeks and within 3 months of getting that second dose. Now, somebody else asked me, does that mean that the vaccination will only last for 3 months? And that I don't know. I think there's a finite amount of time the vaccine's going to last, but that's just an arbitrary number that they picked out. I don't think that's based on any science of how long the vaccine's going to last or how long it's going to be effective for us. Next question. We received a 2567 in December. We got written up for staff taking care of both yellow and red zones. Of course, staff use proper PPE when moving between zones. The write-up indicated that staff must be dedicated to one zone only. Of course, it makes sense to have dedicated staff, but we're dealing with an outbreak, so short staff. Now we have one patient in the red zone. Do we have dedicated staff for just that one person? And somebody else reached out to me and gave me that same scenario or a very similar scenario. And I'll give you the answer that it says in the AFL, and then I'll tell you my opinion about it. But the AFL does not differentiate. For those in the red zone, they have to be dedicated. That's what the AFL says. Whether it's one resident or 100 residents, it does not differentiate. We know that is impossible. It's just not possible to have an entire staff team dedicated to just one resident. I think in those instances, we do know that in terms of how you protect somebody, if you have that staff going from yellow and then into the red, where they work a portion of their shift in yellow and then a portion of their shift in red, from a patient safety standpoint, that's about the best you can do. And I'm not certain there are any other reasonable options without impacting patient care in other sides of the house. And so I just don't think it's feasible. And I think when you have that conversation with the district office, one, I would say, no, we don't deserve to have that. And this is the reason why. And even though the AFL says that, it's based on recommendations from the CDC. And the CDC does not say you have to. It says you should, and you should if you can. But if you can't, here are the options. And those are the things that we got to go, hey, look, operationally, it's not possible. I'd love to do it if I could, but I just don't have the ability to do it. And that has to, if it's impossible to do, we just have to say it's impossible to do. If you get a district office that says, look, I don't care if it's impossible, it doesn't matter, then please let us know. We have to take that right to the top. It's infeasible. Yeah. Oh, sorry. Patty.
Hey, I am on. I'm so sorry. I kind of snuck on. This is Patty with the Director of Regulatory Affairs for CAF. I kind of snuck on late, so I didn't want to interrupt anything. But On this one too, make sure you have the conversation ahead of time with your district office, not after the fact that they identify it themselves, because they could issue an IJ on it. I think this is an upfront conversation, an open and honest conversation with your district office. But just be aware, having that conversation in itself may trigger them to, obviously, my opinion, to come out and look and see what you're doing as well. So you really want to take all those factors into consideration on this. And in our personal opinion, I fully agree that it's impossible, and it's an impossible situation. But as we know, sometimes under regulation, that may not be taken into a consideration on a scope and severity level. So we just want to balance all that out really well. I will have additional conversations, and so will Jason, on that particular subject with CDPH as well, hoping that that will that they'll be reasonable on that.
Yeah, what we hope. It's just,
but we can't guarantee. Yeah, no.
Yeah, it's and a lot of this is, those individual surveyors really sticking to the letter of the AFL, and the AFL does say that. I mean, it's very clear that it says that it's dedicated staff to the red zone. Now, with the green and yellow, there's been talk of and allowances for being able to have them work both. And that's because they realize that we can't have three distinct cohorts with three distinct staffing models. It's really hard. But two distinct staffing models is hard when you only have one patient in a red zone. It's virtually impossible. So we understand that. All we can do is give them that information and point it out as plainly as we possibly can. So, and I wanted to read to you guys the information from the CDC before I forget. So, the CDC considers a history of allergic reactions to other vaccines or injectable therapies. And it goes on to say, as a precaution, but not an contraindication to vaccination, these persons with a reaction to vaccine or injectable therapy that contains multiple components, one of which is PEG or polysorbate, but in whom it is unknown which component elicited the immediate allergic reaction. So those two specific components, PEG and polysorbate, look to be, and they have not been able to identify which one of those two has caused the immediate allergic reactions. But if you're talking to your staff or your residents, or you're reviewing their chart, that's what you're looking for, is making sure that they don't have that contraindication. So I wanted to get back to that because I couldn't remember the second thing they mentioned. All right, so is POC required to report to NHSN? And I think if you're reporting through the SNF Daily Survey, they're doing the reporting to you. But Patty, I'm not up on the NHSN reporting. I'm assuming that's going through the SNF 123 survey, and then CDPH then uploads that information into the NHSN. Is that correct? If you're talking, we can't hear you.
Oh, sorry, Jason, can you repeat the question?
Oh, sure. I was just saying that when folks are reporting on their SNF 123 survey, they're reporting their testing results. The CDPH is then passing that information to NHSN, correct? And the only time we would input that information into NHSN is if we were not doing the CDPH survey. Is that correct?
Well, it depends on if you've conferred your rights to, are you talking about the survey daily reporting hub?
Yeah.
If you've conferred your rights over to CDPH, there's certain areas, I can't guarantee it, and I don't really want to confirm right now. There are areas that are not pulling over to the NHSN, and it's because CDPH is not going to push that. Even if you've conferred your rights over, there's areas in the NHSN that you have to look at on a weekly basis to make sure all fields are complete. We have seen facilities that have conferred their rights over still getting multiple citations issued for the NHS side, because some of that is not going over regarding I believe testing and other areas. I can't at the moment. I've tried to get the them to let me know exactly which areas weren't pushing over on the CDPH side, and they have yet to let me. They haven't clarified that yet. They were looking at a couple of issues with providers right now that have received the penalty letters, but there's information in NHSN that is not being pulled over, even if you've conferred your rights, because things have changed. And at one point they were going to wait and do a software update that could just directly go to NHSN through another system regarding the testing stuff. And so it's become a little convoluted. And so you'll have to look on your NHSN site weekly to make sure that, if you look a couple times, and it's the same information you've been transmitting and it's going over fine, there's nothing blank on the NHN side, then you're perfectly fine. Where we're finding a few glitches and we're finding some areas that aren't getting transferred over, and that's where you'd have to go check. So I don't want to 100% say you're okay, because you may not be.
Right. Thanks, Patty. And so I think that's the message. Trust but verify. Make sure that the reporting data is what you're submitting. Next question. This is a follow-up from last week's question regarding validating self-reported lab-confirmed positive test results for residents who are unable to provide documentation. Per LA County DPH, we need to treat as though the resident has never been positive and continue to test. The challenge is the resident may test positive. I'm sorry, it cut off your question. Let me expand this. The challenge is a resident may test positive with surveillance testing, and facilities should still follow protocol for lab confirmed positive result. Yeah, and that's unfortunate. I reached out to Los Angeles County. They gave me the same information as well, unless you could get the records from the test. They confirmed that was exactly it. They want them to be treated like a new person who had never been positive. Makes no sense to me, but I've got to kind of follow their lead on that one. We are not using the antigen POC devices or tests, as our lab has been getting us results within 8 to 10 hours on average. Do we throw them away as they expire? No, please don't. Is there a place to donate them before they expire? Sure, I will take them and I will give them to folks. I'll give you the CAF address. I see your name and I know who you are, so I'll send you the CAF address if you're willing to. If you have the Abbott Now Binex cards, those are the ones that we would be interested in. If you got one of the antigen devices like the Sophia Quidel or the BD Veridor, we wouldn't be interested in those devices. I don't know that those will be much in use after this, but they may be in use if they develop other kind of tests that go with it. But the Abbott Now, there's folks that are clamoring for these, and if you've got those test cards and you're not going to use them, by all means, I'll give you an address and you can send them to me and I'll distribute them to folks that want them. I'm curious, there was a suggestion that restrictions will be loosened, possibly if vaccinate twice and within 3 months of vaccination. We were all vaccinated in December. By the time new recommendations are published, we may be out of the safe window again. Yes, you're right. Like I said, I think that 3 months is just an arbitrary mark that they put there. I don't think that's what they're thinking in terms of the protection will last that long. I do think the protection is finite. It has an end to it, but what it is, I don't know. And I don't think they know either. Obviously, it would be different for each individual person, but as in an average, I think it will be over 3 months. They just don't know. And they want to put just like a metric in there. I do think, we'll revisit that again at the end of 3 months. Certainly, I don't think the recommendation is going to be to get vaccinated every 3 months. So obviously some change will have to come in regards to that. Would you please expand on the retrospective data that needs to be entered back to 2.1? The therapeutics module, vaccination data modules, is this reporting something all SNFs need to do? Patty, since I've got you on the phone, can I pose that question to you?
Yeah, you'd have to repeat it because I wasn't really sure what they're asking, Jason. I did hear the question, but it can one more time so I can make sure I've got it correctly.
I think there was some traffic that went out to the providers that they would need to go back and re-enter data into NHSN back to 2.1, and they would have to go into the therapeutics module and vaccination data modules. I believe, and based on what I heard from Rose Chen from HSAG, is that if you will, one, verify that it's correct, and if it's not been entered, each person's going to have to go back and recreate that. But if
Yeah.
Patty knows, yeah,
Yes, my
yeah,
understanding as well. I can always get confirmation from, if you want to email me that question, powens@caf.org, and then I can flag it to follow up with the answer I get from CDPH just to double check. Then I could do that, and then Jason could reply back with the answer again next week too. And I just would like further clarification on that.
yeah. And next question, what lab gives PCR results within 8 to 10 hours? Please share, exclamation point, a million times over. I can't do that on the form, but Jared, if you want to share it, I'll send it along to that other person. And then can you send me your address? Also, we cannot use them at our facility, but they continue to send them to us. Fantastic. I definitely have folks that will use those, and even if they're so if you're a skilled nursing facility and you would like to get a supply of those, as I get them, I'll take your name and I'll send them out to you. Also, for if you're an intermediate care facility on the call and you would you want to be put on that list, by all means just email me directly, jbelden@caf.org, and I'm happy to take a list and start sending folks out. If you guys aren't using them, we'll take them all. So, all right, I don't have anything else. Patty, did you have any words of wisdom for us before we send folks off for their Valentine's weekend?
No, just gear up. There may be some AFLs dropping tonight. I'm not sure. There's one that I know that we've submitted some comments on. It might be dropped. It might get dropped tonight or it may not. But I do know that we have some pretty heavy draft AFLs out there still with CDPH that will be in that packages that CDPH is working on. That'll probably be dropping next week. So we'll provide clarifications for that for you. And again, if you have any regulatory questions, like for example, today I'm working on a lot of things regarding surveyors in the building or staffing audits going on in buildings, that sort of thing. If you have any questions, just email Jason or myself or any of the CAF team directly. And involving us sooner than later is always better.
Yeah. Well, I want to say thank you very much, Patty and Jamie and Summer. You guys have helped me immensely through the last year. I can't say thank you enough to you guys out in the field. You know, it's a slog, and I know folks are tired, but we're almost to the end here, guys. So hopefully you enjoy your Valentine's weekend. Hopefully you get a chance to take some time for yourself, eat some chocolate. I don't know, do something else, whatever the case, whatever makes you happy, do that this weekend, guys. So take care. Have a great day. Thanks. Bye-bye.